men listening in tonight who are in that less than 55-year age group who are on active surveillance and what their thinking is and what their doctors mentioned. Here's a study that came out last year in the Journal of Urology by Feldman. This is looking at active surveillance in men younger than 60. It was a retrospective study from Mass General in Boston, 417 men less than 60. The average age was about 55. They compared that to about 1,600 and some men age 60 or older, median age is 69, and the average median follow-up was about 6 years. And they showed the same 5-year progression-free survival, about 83% in both arms or both groups, and about 70% were treatment-free at 5 years, and about 31% of young men eventually underwent treatment over that median follow-up of 6 years. And so the key conclusions were that men under 60 can still be offered active surveillance and left. They also looked at something called Psa density, which is ratio of the PSA to the prostate volume, and they said if it's greater than 1.15 or a single biopsy core of greater than 20% cancer, they were a little bit reluctant to recommend active surveillance. But then they go on to say a randomized trial is needed to confirm these findings, so it's preliminary. Here's another one. Older age predicts more grade reclassification. So this is a study, again, from 2019 from Druskin and al. Journal of Urology. 1,625 men on active surveillance from 1995 to 2016 in the Johns Hopkins active surveillance study. And they looked at the outcome was Gleason grade group 3 or greater progression. Grade group 3 means Gleason 4 plus 3 equals 7. And they found that in young men, it was actually less than in older men. So basically, they said, be cautious in healthy older men. Don't be too quick to switch, from what they call active surveillance to watchful waiting, meaning don't age discriminate in older men, just kind of blowing them off. You better, if they do active surveillance, those men can have higher grade cancer lurking in their prostate as they get older. What about high volume Gleason 6? So guy comes in, has a biopsy, but has a lot of cores. We typically do about a dozen cores, and let's just say has, more like 5 or 6 of those Gleason 6. It's really unclear. The problem is it really truly Gleason 6? And that's really the crux of the matter whenever we're talking about active surveillance. Is it really low grade, or is there some bad stuff lurking in there? So if you truly knew if that was Gleason 6, then probably active surveillance would be okay for everybody. In practical terms, in my practice, certainly if more than 4 cores of Gleason 6 are present, I'm a little bit more likely to recommend molecular markers or MRI at their first 6-month follow-up visit to make sure I'm not missing or make sure there's not something worse hiding in there other than the 4 or more cores of Gleason 6. So, does higher volume Gleason 6 portend more hidden Gleason 7? Probably. And does higher volume Gleason 6 portend a higher chance of a positive MRI? Well, probably, because, but not, again, it's about 30 or 40% of the time those men with Gleason 6 probably actually have more cancer than what we think. Then the whole issue, if it's truly Gleason 6, which is grade group 1, some people are questioning whether that's even should be called cancer. And so it's not so much the Gleason 6 that I'm worried about, it's the fact that how often is something else lurking in there that's worse than Gleason 6. As far as active surveillance criteria, and I suspect a lot of you guys on the phone or on this call tonight know a lot about this, but these are just some of the different studies around the globe that have looked at active surveillance. In those particular hospitals or groups, these are the patients that they generally think are good candidates for active surveillance. You have to have low stage disease, kind of low grade disease, not that many cores involved. But again, the key teaching point here is that it's not, different groups have different criteria. So it's not written in stone who should or should not be offered active surveillance. Defining intermediate risk prostate cancer suitable for active surveillance. We talked about this a little bit earlier. This is a study from Stacy Loeb, who's a urologist at NYU in New York City. This was published in February of 2019, and this is an observational study of the National Prostate Cancer Registry of Sweden, looking at 2009 to 2012, examining radical prostatectomy pathology. And it was 5,087 men with low and intermediate risk. The conclusions for grade group 1, which is Gleason 6, expand the criteria for active surveillance to men with a PSA up to 15 if the PSA density is 0.15 or less. So their conclusion here was active surveillance may not be prudent for most men with PSA greater than 15 or men with a Gleason grade group 2, which means Gleason 3 plus 4 equals 7. And then, so I'm interested when we get to the question and answer session is, are there men on the call tonight who have Gleason 7 or higher who are on active surveillance who would like to comment? Active surveillance, what is the role of prostate MRI? And, MRI is the hot topic. Everyone thinks it's the greatest thing since sliced bread, and it definitely is better than it was 5 or 10 years ago, but, it's not perfect. And the current guidelines do not provide clear guidance. And so should all or only a subset of patients have an MRI before the patient is offered active surveillance? And when is it reasonable to forego the confirmatory biopsy for an MRI? In other words, let's say you go on active surveillance and you're at your 1-year anniversary. And so the urologist says, oh, you need another biopsy, a confirmatory biopsy. And you say, well, I don't want another biopsy. I'd just like to do an MRI. And we don't really know if the MRI can replace a repeat biopsy. So my practice, and I'm not sure if this is right or not, I generally do not recommend MRI before starting active surveillance for many men because it's not perfect. And again, I think a lot of men with low volume Gleason 6 can probably start active surveillance without an MRI. But in young men and men with Gleason 7 or higher volume Gleason 6, I will commonly order an MRI at the first 6-month follow-up. I think the 1-year confirmatory biopsy is more important than the MRI. So I still follow the guidelines and say, hey, I think the guy needs a biopsy at 1 or 2 years and not completely rely on the MRI. So just headlines, prostate MRI may have active surveillance benefit, and it's definitely a hot topic, but there's still controversies. This is a study quite interesting from Dr. Laurie Klotz. Laurie Klotz is in Toronto. He's one of the godfathers, if you will, of active surveillance. And this was a study that was published in European Urology in 2018. It was a 3-site randomized control trial of standard biopsy versus MRI fusion biopsy for confirmatory biopsy. And this was low-risk men diagnosed within 1 year of study randomization. And they basically found that upgrading occurred in 23% of the standard biopsy versus only 14% of the fusion biopsy. And the addition of MRI targeted biopsy to conventional sampling at confirmatory biopsies in men with low-risk prostate cancer does not increase the rate of cancer upgrading. So in other words, this study really was kind of negative. It says that the regular biopsy actually does a better job of picking up cancer than the MRI. But the critique of this is the 3 sites, they had unbalanced results, and basically the experience in reading the MRIs probably varied quite a bit among these 3 different sites. So then here's another one on fusion biopsy. Basically, and I know I don't want to spend all the time on the slides, but they said they looked at Bloom looked at 542 men from the National Cancer Institute prostate MRI series who had grade group 1 or 2 and had grade group 1 or 2 and had confirmatory fusion biopsy and active surveillance. 111 or 20% had a negative fusion biopsy. A negative fusion biopsy independently predicted low rate of progression. So basically, in this study said that, okay, if you did an MRI and then you did a fusion biopsy, meaning you biopsied based on what you saw in the MRI, and that fusion biopsy was negative, showed no cancer, then you were pretty cool to really not do any more biopsies for 2 or 3 years. So in this, from an individual patient standpoint, this would be pretty great, meaning you did the MRI and you then did a repeat biopsy and it was negative, then you pretty much might be home free for a couple of years before you had to do anything further invasive. This is, again, another one looking at the volume threshold for Gleason 3 + 4 = 7. In other words, answering the question, okay, you know, if you have Gleason 7, it's a little worse than Gleason 6. You want to go on active surveillance. Is it safe? And here may be the ideal setting where molecular markers can be helpful, like Polaris and Oncotype. And so my practice, if a patient with Gleason 7 desires active surveillance, I tend to recommend a molecular marker. And more than 2 cores of Gleason 7, especially when the core volume is greater than 20% and the patient is healthy and less than 70, worries me. So in other words, more than 2 cores of that Gleason 7 is a little bit worrisome. I would generally offer an MRI at 3 to 6 months after the biopsy, and a Gleason, higher volume Gleason 7 who really desired active surveillance. I'm a little bit reluctant to offer active surveillance in African American men with any Gleason 7, just because my concern is higher recurrence rates, but I'm not sure if my practice is correct in that regard. Then this is another one on what about molecular markers needed for low volume Gleason 6? In other words, you have a guy who's the ideal candidate for active surveillance. He has maybe 1 or 2 or maybe 3 cores of Gleason 6. Do you really need to do anything else to prove that he's a good candidate for active surveillance? Probably not. You know, as we get more comfortable with active surveillance, the men with low volume Gleason 6 are generally fine to start active surveillance without other testing. For low volume Gleason 6, the molecular markers on the biopsy tissue sometimes are non-informative, meaning it's insufficient cancer in the first place. You send it for a molecular marker and it comes back non-informative because they didn't have enough tissue to examine. And so for all except the youngest, healthiest men, low volume Gleason 6 stands alone as an ideal patient to start active surveillance, in my opinion. What about some of these other, you know, blood tests? Here's a study on 4K score, which is a blood test, and looking at different cutoffs. And I would say right now the guidelines don't really feel that 4K score or prostate health index are necessarily useful in active surveillance. And then this is a study looking at the University of California, San Francisco active surveillance series, looking at what they call a PIRADS-2 score. In other words, in plain English, they were looking at MRIs in a group of guys who were on active surveillance and grading those MRIs as to their suspicious, you know, how much suspicion there was of prostate cancer. And they basically say that a higher GPS, which is one of the Oncotype GPS score, or a PIRADS score of 4 or 5 showed an increased risk of upgrading. In other words, just some data to say that, hey, in some men where they're on active surveillance, if the molecular marker really shows that things might be a little more serious, or if in follow-up the man has an MRI and it shows a more suspicious lesion or, you know, abnormality in the prostate, that patient probably needs another biopsy, or maybe better switching gears and going off active surveillance and having treatment. You know, the frequency of optimal biopsy frequency, and how, in other words, should some men have a biopsy every year, every 2 years, every 3 years? The actual answer is unclear. The initial Johns Hopkins series of active surveillance basically recommended that men get a biopsy every year. Subsequently, I think some of the later studies will say that maybe every year is overkill. Most of the studies seem to still think that that 1 year confirmatory biopsy is important, but men with a negative confirmatory biopsy, in other words, men who don't have cancer on that second biopsy, probably don't need a third biopsy for 2 or 3 years. In men who refuse a confirmatory biopsy, then multiparametric MRI might be a substitute, but we're not sure, and it's not yet endorsed by the guidelines. And then, you know, another key question: at what age to stop further biopsy? So, for example, when do we convert from active surveillance to something less intense as men get older and develop other health issues where prostate cancer is going to be less of a concern to them? And we don't know that answer, really. You know, this issue of a confirmatory biopsy. And again, the practice seems to be doing a repeat biopsy or that confirmatory biopsy at 1 to 2 years after their initial diagnosis. I'm going to just skip into just a final slide before we open it up. And, you know, what do we know about active surveillance as of December of 2020? And I would say, I mean, in general, most men with Gleason 6 are candidates if they truly have Gleason 6. And that the truly part is the part that we're struggling with, is how much of the time is something else worse that's hiding in their prostate. And it seems to be about 30% of men have occult worse disease and will fail active surveillance in the first 1 to 5 years. And we have no perfect way right now to find those 30%. As I've said, we use MRI sometimes, we use molecular markers, we use repeat biopsy, we use MRI-directed biopsy, but there's this sampling error. I think about 1/2 of men placed on active surveillance will be long-term active surveillance patients, up to 10 years or more. That seems to be confirmed in a bunch of studies. Healthy men should have that 1 to 2 year confirmatory biopsy, and the role of MRI kind of remains unclear, but popularity is increasing. The biggest challenge we face, I think, is quality assurance of MRI, because the quality varies from hospital to clinic to regions around the country and the world. So I will stop there, I think, and would like to just open it up to questions at this point. And I have a lot of other slides that we can go through if the question relates to it.
And Judd, this is Howard Walensky. Maybe I'll kick it off with a couple of questions. Anybody who tries to keep up with the news on this probably has read in the last day or so news about FDA approving a Pmsa test. And in fact, we did a program on Monday where we had Dr. Westphalen from University of Washington who showed us some video of what the test was like. And I'm wondering what the value is of this potentially for men on active surveillance. Is this really for men with more advanced disease, or what's the story?
Yeah, great question. So, you know, PET scanning and prostate cancer is a really hot topic. For the last 2 years or 3 years, we've had a commercially available PET scan in prostate cancer called Axeman, and I'm sure you guys have discussed that on some of your previous programs, but it's fluciclovine. It's an amino acid PET scan, and it's commercially known as Axeman. And that is approved to look at recurrent prostate cancer after radical prostatectomy or radiation. It's not FDA approved in any way to manage active surveillance. The new PET scan that just got approved is interesting because it's a gallium PSMA PET. It's basically a different radio tracer that's attached to gallium, and it only got approval on the West Coast, I think at University of California, San Francisco, and at UCLA. So that new FDA approval is limited to those two medical centers. And so it's not going to be widely available in the United States, at least for a while. And it was only FDA approved to work up recurrences after surgery or radiation, not for active surveillance. I will tell you in practical terms, many insurance plans will not even cover the Axeman PET scan for the indication that the FDA has already given it. So it's amazing how often the Axeman PET scan gets denied coverage, even for indications where the FDA thinks it's useful. I dealt with a patient just in the last week who had a radical prostatectomy, and now his PSA is about 0.6, and he's trying to decide if he should take radiation. Now, the Axeman PET scan is clearly on label for that. That's the way it was FDA approved, to be used specifically for that. And yet Blue Cross and Blue Shield of North Carolina says that it is experimental, it's not indicated. And I tried to appeal it, and the appeal went nowhere. And so the day that, so basically he has to pay, he was offered to pay cash for it, and the discounted cash price was $5,800. So these are practical issues. So I think, Howard, it's a great question, but we can't even get them to insurance companies to pay for PET scanning for patients where it's clearly on label, much less for active surveillance.
And I'd like to sneak one more question in about another thing that in our active surveillance circles that we talk about is reclassifying Gleason 6 is non-cancerous or precancerous. And I know there's been some debate about it, and I just wonder which dog you have in the fight.
I mean, I think right now, Gleason 6 is still considered prostate cancer. And I don't, I'm in the trenches taking care of patients at this point, and I haven't heard, I can't imagine, it would be like moving an aircraft carrier, it doesn't move quickly to try to change something fundamental as getting rid of that category and calling it precancer. So I know I've heard it talked about in academic circles, but in practical terms, I think for the foreseeable future, Gleason 6 is still going to be considered prostate cancer, but we're recognizing that a lot of those men can be monitored. It's just that I really don't know. I'm really worried about the high volume Gleason 6. I mean, sometimes you see guys who have, 5, 8, 10, even or more cores of Gleason 6, where the whole prostate is replaced by Gleason 6, if you will. And I worry, those guys I just worry about is that the right thing just to monitor that high volume disease? And I don't know the answer.
Yeah, no, I'm at a disadvantage because I can't read the questions. And
yeah, I was gonna jump in, Howard. So Dr. Moul, we got a question from Michael. I'll just read you the question, and then it's personal, but you can make it as general as you need to. I was diagnosed with Gleason 7 1 core, but the category 4 percentage is only 5%. My understanding is that Gleason 7 with low volume category 4 behaves like Gleason 6. Does the evidence support that conclusion?
That's a wonderful question. I can't provide specific medical advice, but in general, a couple things that I would want to know as a clinician is I would want to know the prostate size. And the reason is that, and this is so common sense, but yet it sounds so weird, but if you have a physically big prostate, you can have more cancer in there and there's more room for it to grow so it doesn't escape. And so the first question I would ask is, okay, it's low volume, it's a Gleason 7, it showed up in one core, I guess. It was 3 plus 4, but the 4 component was a really small amount. So it just barely got into the Gleason 7 category and not the 6 category. I would say if that gentleman has a fairly large prostate, in other words, has BPH, I would be more comfortable saying, hey, you know, not too bad. You got a big prostate, you got a little bit of cancer. It's probably going to take a long time for that cancer to escape your prostate. You're probably cool to do active surveillance. But if that guy were a younger man or a man who was in really good health, I would want him to have another biopsy. I would want him to have a confirmatory biopsy at about 1 year follow-up, or maybe stretch it out to 2 years. But he's cool. I certainly think he's cool to do active surveillance. I would have no problem with active surveillance.
I ticked off a lot of the boxes that when you were asking the questions in red, like if there's anybody with a 3 plus 4, that's what I have. When I had my biopsy, I did everything. I had the 4K score, then an MRI, then the biopsy when I was first diagnosed. My biopsy had 6 positive cores, but only one of them was 3 plus 4. And it was only 15% of that core was 4. That all said, what was I going to say? So I did the genomics. So that was I think that was your question was, and I'm also 62, so I'm on the young side.
Yeah.
And I really was leaning towards active surveillance the whole time, but my surgeon at MSK, who is Dr. Aday, wasn't really super happy with it unless we did the Polaris test. So we did the Polaris test and it came back low, favorable intermediate risk. So we decided to go ahead and do active surveillance. But my plan, which is different a little bit from what you were saying, is an MRI at 1 year, an MRI at 2 years, and PSA tests along the way every 6 months, and digital rectal exams, and a confirmatory biopsy not until 3 years.
Wow, that's very bold. I would be very. You're only 62.
Yeah.
I would, man. I think you're playing with fire.
Well, that's really interesting
because MRI, everyone thinks MRI is the greatest thing, but there's a lot of reading. Again, if you're getting those MRIs at Memorial Sloan Kettering, I would say if you're getting those MRIs at a real center of excellence, then perhaps. But at 62 with 6 cores positive, waiting 3 years, I would be very uncomfortable with that. Because I'm 62, there's no way I would do that myself.
Mm-hmm. Okay.
But again, I'm not allowed. We're probably shouldn't have even said that. I mean, just being open and honest.
I know. I'm glad you said it, because my understanding, like after going through a million different webinars, pretty much everyone talks about that confirmatory biopsy after a year. And so I'm not really 100% sure why the plan is to wait for 3 years, but we will see. Yes, I'm getting the MRI done at Weill Cornell from a very good person, and I have a specific radiologist who's going to read it. So, but like you said, that's not the be all and end all.
So it's interesting. Speaking now, the MRI. Here's a question at Duke. Our MRI guru. His name is Raj Gupta. He's a great guy, young radiologist who's really dedicated himself to this field. And so he believes that to get the best result from an MRI, that men should have an endorectal coil where they put a probe in their rectum, which gives them a more accurate, he believes it gives them a more accurate reading for the MRI. But a lot of other centers actually don't do the endorectal coil. So even at centers of excellence, Duke versus, another center of excellence, there's variability in what the experts believe to be the best MRI. And if I'm a young guy, when I consider 62 young, you know, I would, you know, well, of course, you're hearing my true colors. I'm a surgeon at heart. At 62, if I had 6 spores positive, I would be looking for the best surgeon I could find to do a nerve-sparing prostatectomy, I think.
Mhm.
But
Elliot, if I could jump in on the MRI a bit. Carolyn Moore, British urologist, has been one who's been promoting the idea that MRI is adequate to monitor active surveillance patients. And I'm wondering, you know, what your perspective is. Is it adequate to monitor some or any? Plus, she is recommending that urologists learn how to read MRIs so they can follow their patients. So, at any rate, maybe you can give me a reaction to that.
so even the radiologists can't read the MRI. I mean, there's tremendous national variation in the quality of prostate MRI. And I see it all the time in practice. I mean, I see patients coming in for second opinions from some of these other places or private groups where the, you know, mom and pop MRI unit, and the readings are truly suboptimal. So, and you look at the, you know, the problem is you have, you know, groups. I admired your group for, you know, being, you know, doing the literature and being students of the disease. When you're reviewing these results from centers of excellence, and yet the United States is a big country with a lot of variability in healthcare, and you know, there's a lot of bad MRIs being done out there, and I just don't know how many patients are being harmed by, you know, being led into this false idea that, you know, MRI is an MRI is an MRI, no matter where you get it done and who reads it. And unfortunately, not every person in this country can go to Memorial Sloan Kettering or a Duke to get these tests. And I just worry there's a lot of people being harmed out there by you know, suboptimal testing. So, you know, again, all the people listening in tonight, you guys are advocates. You guys are sophisticated. And assuming you know what you're doing, and when you're getting your MRIs, you're getting them in the center of excellence. But, and to think that someone's going to recommend a urologist to be able to read these scans, it's not that simple. These are hard scans to read. And you know, a radiologist is a board certified, you know, trained person. To ask a urologist to try to read these things and use that data for someone's health, I think that's a pipe dream. That's not going to happen. I wouldn't rely on any of my partners to read an MRI for my health. I would want a board certified radiologist.
Judd, this is Joe. In line with that, you know, one of the things that had come up in discussion is that, well, when we get certain biopsies done, we often will send that off to get a second opinion on the biopsy. You know, would it make sense to be getting a second opinion on an MRI?
It would make sense, but to have it done practically in the U.S. healthcare system, I don't know how you would do that. For example, who's going to pay the second radiologist to do that?
That's always a challenge, you know.
Yeah.
I don't know if insurance would cover that or not. Yeah.
There's another question. This one's coming from Wayne. Can you expand a little bit on your concern for active surveillance in African American men with 3+4? What is the concern?
So there have been a number of institutional studies. In fact, here's one. We published one from Duke. There have been a number of studies looking at active surveillance in African American men, and virtually all of those have shown a higher failure rate of active surveillance in African American men, including our study from Duke. And it's not crystal clear why that is, but because those retrospective studies have been cautious, then I think there's caution in the field of how which African American patients are the best candidates for active surveillance. And so most of the active surveillance series, the Toronto series, the Hopkins series, even the Canary study, most of the patients in those series have been Caucasian. And so I think we just need more data in African American men, but I think we just have to be cautious about, just be careful and not, and be really mindful and make sure those patients return for their follow-up visits every 6 months.
Thank you.
Just to follow up on that, there's, don't take this the wrong way, but there's something out, I coined the phrase, I wrote an editorial about 5 years ago. It was called dumbass, and it stood for DUMBAS, so dumb active surveillance, which means, there are clearly patients who choose active surveillance even though their cancer is significantly worse than they should be on that they shouldn't be on active surveillance. And sometimes men choose active surveillance by default, meaning they're so scared of the consequences of surgery or radiation, and even though they don't fit any of the criteria for active surveillance, they do active surveillance anyway, and that's called dumb active surveillance. And sadly, we see men of all ethnicities do that, but sometimes African American men tend to be more inclined to take that stance and not follow through on some of the recommended treatments.
Hey, Judd, is there such a thing as smartass also?
That's good. I love it. Yeah, I mean, smart active surveillance is having the patient. There are a lot of patients who are great candidates for active surveillance. Most Gleason 6, lower volume Gleason 6, having low volume, low risk molecular markers, having a negative MRI. So I think there are good candidates or smart candidates for active surveillance, and probably most of the guys that are on active surveillance for appropriate reasons. But we do have I see it in practice, some patients who do active surveillance even though we don't think that that's a good idea.
There's a question. These are very specific questions, but maybe you can generalize it from Marvin. 2017, a biopsy, 1 core, 3+3, 7%, 1 millimeter. But then a second MRI, PIRADS 4. I guess that would be more recently. He didn't say what year. Marvin, do you want to weigh in? When was the second MRI?
That was this year.
Okay.
In June.
Okay, so then a follow-up MRI in 2020. So the question is, do I need an MRI guided biopsy? He's 72. So after getting the PIRADS 4.
Yeah. So I would say, in general, we certainly the last thing we want to do is discriminate based on age. However, we also have to be realistic that age does matter in these decisions. And if that is a very healthy 72-year-old gentleman who has a greater than 10-year life expectancy, then I would say if he had a good quality MRI and the good quality MRI documented a PIRADS 4, then he probably should have a repeat biopsy. However, if he's a 72-year-old gentleman who has other serious health issues or significant health issues, and we see that, then I think it is really incumbent on the doctor and the patient to have a really good heart-to-heart discussion about life expectancy, and some of those patients are great candidates for active surveillance. Even though in a much younger patient or healthier patient, it would be dumb active surveillance, but in a patient who has other health issues, it might be a good decision. You might be a smart ass and not a dumb ass.
I'm pretty healthy, and my dad lived to be 92. So,
Well, then I would say in general, I would probably do a MRI-directed biopsy of that PIRADS 4 area. Although, there's different qualities to the fusion biopsy. Sometimes you can do a formal fusion biopsy with the technology, but then there's also something called a cognitive fusion biopsy, where if it's a large enough lesion or a comparable lesion, you don't necessarily have to do the formal fusion technology. You can just do it almost like the good biopsy doctor can do it without the fusion technology. But that's a whole nother bag of worms.
yeah. Okay. Thank you.
Hey, Dr. Moul, we hit a little bit, but we sort of went around it on biopsies. There's a couple of alternatives to biopsies besides the guided biopsy. We have the routine truss biopsy, and then we have the transperineal. What's your opinion on either of those?
So I've done both, and I will say right now we do still mostly the transrectal biopsies. Perineal biopsy came into play because of the worry about increased risk of infection when you do the biopsies through the rectum.
Mm-hmm.
However, what we've done at Duke is we do every patient who's going to have a biopsy as a rectal swab culture, basically a Q-tip test of the rectum, culturing the rectal, the stool basically for Cipro-resistant E. coli. And by doing that culture prior to a biopsy, we've been able to lower our post-biopsy infection rate to 0.4%, which is not zero, but it's still comparable to the perineal. The perineal biopsy sounds really good because you don't have to go through the rectum, but it takes longer and it's more uncomfortable for the patient to go through the perineal biopsy because you actually have to make a cut in the skin in the perineum. So I would say there are pros and cons of both types of biopsy techniques.
That's consistent with what we've been hearing, from others as well.
There's another question here from Richard. Is the significance of the number of cores positive, the number of positive cores affected by the number of cores obtained? Sorry, let me read that again. Is the significance of the number of cores positive affected by the number of cores obtained, such as in the case of 3 positive cores out of 20 obtained in saturation biopsy?
Yes, I mean that's also, yeah, of course. So I mean the standard biopsy is 12 cores, and 3 out of 12 is what, 25%, but 3 out of 20 is less than that. So yeah, I would look at 3 out of 20 in general as a less important cancer than 3 out of 12. Although, again, it depends a little bit on where those biopsies were positive and how big the prostate was overall. Let's say it was 3 out of 20, but all those 3 were bunched in one area and the prostate was really small, like say less than 20 cc's, then that small tumor, if it's close to the edge of that small prostate, the cancer might escape with active surveillance. Whereas if those were 3 out of 20 cores and a guy had a 50 cc prostate, and they were kind of spread around in the prostate, I would be much less worried.
Thank you. Here's another question from Hugh. We touched on second opinion on MRI. You answered from the point of view of taking the MRI. How about, I think we talked about this, just a second opinion reading it. That's when you said it's hard to, I think you answered that saying that it's hard to get the healthcare to pay for it.
It's also hard to find, how do you know who even myself in the field, I mean, I know my one guy at Duke is the guru, but he's not the only guy at Duke reading MRIs. And to be totally honest with you, he's really the only one that I know. I don't know how good or bad some of the other ones are. There are. There's no way. I don't know how to learn that information. And let's say a guy comes in, and he brings a CD and says, I want a second opinion in my MRI. Okay, I send it to radiology, and I can't guarantee that the guy that I know is going to get that to read, because there might be 4 or 5 radiologists who are reading those things.
Right.
And so
that leads us to the next question, literally, which is, how do you vet an MRI provider to ensure you get a good quality reading? So, like, is there anything we can do in advance other than maybe try to go to a center of excellence to figure this out?
That's a great question. And the honest answer is, I don't know. Like, for example, I work at one hospital, and I know my go-to guy at my own hospital. But I don't know how many folks on the call have ever been to the Triangle area of North Carolina. So, I work at Duke University, but UNC Chapel Hill is like 10 miles away. Like, we have these 2 major universities within 10 miles of each other, and I live in Chapel Hill. I have no, if I got a call from my neighbor and he said, hey, I have prostate cancer, and they did an MRI, who at UNC is the guru for MRI? I have no idea. And I'm right here in the same town, and I'm a prostate cancer expert, if you will. And so, but I don't even know who the MRI guy is at the hospital in my own town. How would a patient know that?
I know that's our struggle, obviously.
Yeah, well, I mean, you're right. It's and everyone, I think some people think that this MRI is like universal, and it's so variable in its, and how it's done and how it's read and how it's interpreted. At least the molecular markers are a little bit more standardized, meaning, you send the tissue to one lab in one city, it's all done in the same lab, and you get a number back, an oncotype. If, let's say, you do oncotype or Polaris, that's certainly a lot more standardized than the wild west of MRI around the United States and the world.
Elliot, if I could dive in for a second.
Yeah, sure. Sorry, Howard.
We talked here about second opinions with the MRI, second opinion with that. Well, let me ask you overall. When should men seek a second opinion?
That's
broadly.
Yeah, it's a good question. I mean, I think, let's just say a guy has, there are a lot of cases that are pretty cut and dried. I'm not sure a second opinion would help. Let's just say, you're a middle-aged guy and you had a PSA like less than 10. You had a biopsy, and let's say you had 1 or 2 cores of Gleason 6, and I'm not sure that guy is going to need an immediate second opinion, because almost everyone's going to recommend active surveillance. Now, again, it doesn't hurt, because it's the second set of eyes looking at the numbers, looking at the situation. Maybe making sure that the prostate volume is looked at, making sure they look at the Psa density. Maybe a molecular marker would be helpful, but it's a good question. I mean, some of it depends on the trust too. I mean, and if you have a really early straight, you might not need a second opinion right away, but maybe a year later, let's say when you get a confirmatory biopsy a year later and the cancer is worse, or you get there are situations where maybe on active surveillance, you might not need a second opinion right away, but you might want a second opinion if the doctor says your cancer's gotten worse. Perhaps. Again, I'm sorry I'm beating around the bush, but there's no really easy answer for that. Some men are just distrustful, or some men, do a lot of research no matter what they do. Buying a new car, getting a new TV, those are the guys that tend to, second guess everything and want to get a second and third opinion. I see a lot of people that want a second opinion even on their first biopsy, whether they should pull the trigger for a biopsy, even just for a moderately elevated PSA. So it's all over the map.
And I can tell you personally, 10 years ago, almost to the day, I got a call from a urologist I'd seen because my PSA had been elevated, not quite to 4, but it had gone up sharply in a year. I did a biopsy, it was ambiguous, and so automatically it triggered a second opinion. Actually, maybe I should ask you about that. What are a PIN? If that shows up on a biopsy, what is PIN, and is that something to be worried about?
So PIN, for the guys on the call who may not be completely familiar with that, PIN stands for prostatic intraepithelial neoplasia, and we just call it PIN. Years ago, let's say 10, 20 years ago, more than 10 years ago, probably like 20 years ago, the experts thought that PIN, if you found PIN on a biopsy, it was definitely a precancerous lesion. In other words, if you found PIN on the biopsy, the guy definitely needed another biopsy because you might have missed cancer. But then more recently, over the last decade, it seems that the importance of PIN has declined. That the early studies said that if a guy had PIN and you did another biopsy, up 50 to 75% of the time, you'd find more cancer. And some of the later studies show that rate is as low as 20%, which is almost like a healthy man because prostate cancer is so common. If you stick a needle in a middle-aged man's prostate, that's the problem. You're going to find cancer in quite a few of them, and not all of those cancers are important. So, bottom line, Howard, to answer your question is, if I had a guy who just had PIN, I would not necessarily treat that man like an active surveillance patient. PIN is not cancer. PIN may not even be precancerous. And for most of the time, I kind of am fairly low key now on PIN and will simply recommend the guy coming back and see me in 1 year for a PSA test and a rectal exam.
I see. Well, in my own case, my family doctor was freaking out at the PSA. He was freaking out at the PIN. And so Dr. Epstein down at Johns Hopkins was going to be a speaker for us later in December. He recommended that I have another biopsy in 6 months. And that one showed tiny sliver of cancer. And I should note that every subsequent biopsy and MRI I had showed nothing. And yet, the surgeon, was hanging crepe and was urging me to have, he says, I have bad news and I have good news. The bad news is you have cancer. The good news is I have an opening in my operating room next Tuesday. And so I said, what do you think about active surveillance? He said, I don't support it.
But how long ago was that?
10 years ago, literally this month.
Well, a lot has changed.
Yeah,
Most
I've
urologists,
watched them.
would not have that attitude anymore. In fact, they shouldn't have that attitude. They should be embracing active surveillance for patients with low volume. Now, just to play devil's advocate, you probably, in my opinion, you should have never had that biopsy, because
Right.
you would probably be sitting here, you probably would have never then known anything was wrong with you, and you wouldn't have 10 years of concern about this.
Right, you're absolutely right. But, I'm what you call a compliant patient up to a point, up to the point of the surgeon. Yeah.
They probably, I hate to use the term, but and please don't take this the wrong way for the folks on the call, but you probably had what they call autopsy prostate cancer, which a lot of us might have. In other words, we know from autopsy studies that us guys, if we die of something else, like a car accident, gunshot wound, heart attack, and if you do an autopsy on the prostate, like a lot of us have Gleason 6, little focuses of Gleason 6 prostate cancer that never harms us. And so the problem is we've been a little bit too aggressive. Guy gets a biopsy for, pretty commonly, and you certainly don't want to miss bad cancer, but the consequences of trying to do a good job of not missing bad cancer is picking up too many good cancers or minor cancers. And so I don't know the solution to that, but it's a happy balance between picking up the bad cancers and not overdiagnosing the low volume Gleason 6.
So I ended up getting a second opinion at the University of Chicago from Dr. Egner there. And he said, you don't need surgery. He said, you're going to be the same as you are 10 years from now. And I can attest that I am, and even better. So
yeah. Well, you saw a good man at Chicago. I know Scott, he's a really good doctor, and he obviously did the right thing. You did the right thing. And
yeah, but I think about all the other guys who didn't stand up for themselves and ended up worse off with impotence or incontinence.
Yes and no. I mean, again, you're right. I mean, let's say you have 100 guys like you, and let's say they all had a radical prostatectomy. Well, you're right. We know from previous series that the good news, bad news, that 80% of those men would have never regretted that decision to have that surgery, because they put they put it behind them. They didn't have to worry about active surveillance. They didn't have to worry about going to the doctors and getting MRIs and PSAs. 20% of them were not happy because they might have had incontinence or impotence or regretted that decision. So, it's hard to say, but there were probably a lot of men who had surgery, even for low volume Gleason 6, and don't have any regrets because they had a good outcome and then don't have to, just don't have to even think about it.
Yeah, well, it's an interesting point.
Yeah.
Maybe you can dive in, or Joe.
Yeah, there's a number of other questions. I was going to try to get to the next one. There's two questions in a row about BPH. I'll read them both because they might be related. What procedures might you recommend to a patient to relieve moderate BPH symptoms in a Gleason 6, less than 1 centimeter with a 3.1? And then the next question says, what treatments for an enlarged prostate, TURP, Urolift, etc., would limit or eliminate imaging or cancer treatment options going forward? So I guess it's two questions, like how to treat it and also how to avoid screwing things up later.
Great. Those are great questions. Excellent. BPH, obviously prostate enlargement with urinary symptoms, is pretty common, as many of you guys on the call know, in men who have a little bit of prostate cancer, because prostate cancer and BPH go hand in hand and they're both present. In fact, I'm 62 and I have BPH myself. The management options for BPH include, active surveillance, which is what we're talking about tonight. If the symptoms are not too bad, moving up to medical therapy like an alpha blocker like tamsulosin or Flomax, finasteride or dutasteride to shrink the prostate. And certainly those medications I think are safe in active surveillance, but a lot of those medications have sexual side effects. I mean, I took Flomax for a while, but I didn't like Flomax because it caused retrograde ejaculation. I took dutasteride and finasteride are good drugs to shrink the prostate, but a lot of them have sexual side effects, loss of libido, decreased ejaculation volume. So those are not ideal. The only, you can have a TURP. A TURP is the gold standard, or been around for years, to remove some of the middle portion of the prostate, and that really does not burn a bridge for radiation or surgery for prostate cancer if you need it later. The only downside of a TURP, when you do a TURP, men have permanent retrograde ejaculation. So you really, if a guy has to, it's mostly about the sexual issues. Retrograde ejaculation means when you have an ejaculation or a climax, nothing shoots out of the penis. It goes backwards into the bladder, which doesn't affect the feeling so much. It doesn't really affect, the quality of your orgasm other than psychological, because, it's just different. Nothing comes out. And so that's psychologically not appealing to a lot of men. Urolift is a treatment. These like little titanium like darts that go into the sides of the prostate and pull the lobes of the prostate apart, kind of like a breathe right strips on the nose, except it's done internally. And that requires an anesthesia. It's like a minor surgery in a surgery center. And the good news about that, it does not cause retrograde ejaculation. So you can get a urolift and urinate better, but it doesn't affect your sexual function, which is great. The only problem with urolift is those titanium little stents would interfere with the quality of an MRI. And so if you have prostate cancer on active surveillance and you get a urolift, I think it's going to it won't interfere with a repeat biopsy, but it might interfere with the quality of an MRI if you're using MRI to follow your prostate cancer. Then there's also something called prostate artery embolization, which is not that commonly done, but it's growing in popularity. And to my knowledge, that would be safe and wouldn't interfere with active surveillance. And then finally, you have these other treatments like Resume, which is a high pressure water vapor treatment that kind of cleans out the prostate, similar to a TURP. The advantage to that over a TURP is that apparently there's a little bit less bleeding and maybe a little bit less need for hospitalization. So is that kind of a long-winded answer?
Perfect. I had also heard about something called green laser. Is that one of those that you mentioned?
Yeah, laser is I didn't mention lasers. There's a couple of different lasers that can be used, and basically whether you laser the tissue or remove the tissue using a TURP or remove the tissue using this water vapor treatment, it's still basically plumbing. You're removing the middle portion of the prostate, and that generally causes ejaculation.
Right.
So,
but it also shrinks the size of the prostate. That's
right. So the fundamental question a man needs to ask himself is, how bummed out would he be if, when he has sex and has a climax, how bummed would he be if he doesn't shoot semen out the tip of his penis? And that's, that's a question you have to ask. Is that going to really mess up your life? No pun intended.
There was another question. I think you might have partly answered.
Elliot, let me
Go ahead.
set up a 13-minute warning, because Judd has a hard stop at 9:30.
So should we continue with the questions, or what should we do?
No, go ahead.
Okay. This was, I think you might have answered this, but I don't know the names of the drugs that well. This says, can you discuss the role of 5-alpha reductase inhibitors like finasteride in men with large prostates and urinary difficulty versus alpha blockers like tamsulosin? Do you have a preference, and can both be taken together?
Great question. Yes. So the alpha blockers, and the most common one is called tamsulosin, but we affectionately refer to that as Flomax because that was the trade name when it first came out. So you'll hear doctors and patients talking about Flomax, which is the same drug as tamsulosin, and that's also called an alpha blocker. Those pills, they're taken once a day. Some guys take them in the morning, some guys take them in the evening, but they relax the prostate. They do not shrink the prostate. They relax the prostate muscles so that allows a man to urinate a little better and a little more freely. And that's a common first-line pill or drug that men use for enlarged prostate with urinary symptoms. Then there's the other class of pills is called the 5-alpha reductase inhibitors. And those are the pills that actually shrink the prostate on average by about 30% in a guy who is willing to take those pills every day for at least 6 months. He'll get an average shrinkage of about 30% to his prostate. The two drugs in that 5-alpha reductase class, one is called Finasteride, the other one is called Dutasteride. Finasteride used to be called Proscar, and Dutasteride used to be called Avodart. Those were the brand names, but now they're both generic. And yes, you can use both together. In fact, that is what urologists refer to as dual medical therapy for BPH. And we've done studies showing that both, each drug works good, but if you use both drugs together, you get even a more, a potentiated effect. So the best, if a guy has symptoms, has a lot of urinary symptoms, and wants to get the best bang for the buck out of pills, he would be taking both finasteride or both a 5-alpha reductase inhibitor and a alpha blocker. But they have sexual side effects. Tamsulosin or Flomax or one of the alpha blockers usually relaxes the muscles down there, and so when you ejaculate, the semen doesn't shoot out; it goes backwards into the bladder. So that's for some guys that's a problem. And then the 5-alpha reductase inhibitors, the finasteride or the dutasteride, sometimes those cause loss of sex drive, which is called libido, and sometimes those drugs decrease the amount of semen that your body produces. So you have a lower volume semen amount.
Okay, thank you. There's two, I'm hoping we can get to, there's two more questions that I wanted to try to get to.
Sure.
One is a very specific one, 8 of 12 cores Gleason 6. Hold on, somebody just posted something, so I lost it. 8 of 12 cores Gleason 6, mostly low volume, bilateral spread, PSA density. It says 21 cc's, but I'm not sure if that meant 21%.
Usually, yeah.
Yeah. But anyway, it says PSA density 21 cc's. PIRADS 2 on an MPMRI. Does this make this person a dumbass? I guess because of the 8 of 12 cores.
Well, I maybe I'm smiling. Maybe I shouldn't have used that term, but we're all among friends. That's a good question. I would ask the gentleman, I would want to know his age and health. I mean, I would say if he's 48 years old with that amount of cancer, I would say he probably is a dumbass. But if he's 78 years old, he's probably a smartass. I mean, it's you have to take that into consideration. Now, we'll say this: the PSA, he said 21. I'm sure what that's referring to is a PSA density of 0.21. What that's saying in plain English is that's looking at a guy's PSA level and trying to figure out how much of that PSA chemical or protein in the guy's blood is due to cancer versus due to BPH or enlargement. And a lower PSA density of less than 1.15 indicates that most of the PSA is coming from BPH or enlargement. But a higher PSA density means that he may have more of it coming from cancer. And what that means is he might have more cancer than what the biopsy indicated. So a PSA of 0.21 is not terrible, but the best candidates for active surveillance are guys who have a PSA density of 0.15 or less. And what that means is their prostate, much of the PSA is coming from the prostate gland itself and not from the cancer. And so a low PSA density kind of means there's a low chance of badness lurking in there that you didn't pick up with the biopsy.
Okay, thank you for that. The next question is similar to Howard's question. What are your thoughts on neurovascular invasion if it shows in a man with disease demographics that are conducive to AS?
That's a great question. So perineural invasion or neurovascular invasion, what that means is that the pathologist who's looking at the biopsy under the microscope sees prostate cancer cells around nerve bundles, but those nerve bundles are inside the prostate, not outside the prostate. And years ago, the experts thought that perineural invasion was not good. They thought that that was maybe a bad sign and meant that the cancer was more serious. More recent studies have been controversial. So some studies have said that perineural invasion is not that important. And what I would say is this, is if the gentleman, if everything else indicates that he's a good candidate for active surveillance, meaning his PSA density is 0.15 or less. We know his MRI only showed a PIRADS 2 lesion. He only had Gleason 6. Then I would say go on active surveillance, no problem. Go to your doctor in 6 months, get a rectal exam, get a PSA, and then maybe at 1 year, have a confirmatory biopsy.
Thank you. I think there might be time. I have a very specific question. So, so for someone like me with 1 3+4 lesion and the rest are 3+3, is it possible to go after the 3+4? Is that the danger that because there's a 3+4, that's what's scary? Because that's the one that's going to grow sooner, faster, and grow out, and metastasize. So the question is, could focal therapy be used to go after that one core, that one lesion, and then surveil the rest, or whatever that's called?
I mean, it's a great question, and it's an important question. And the honest answer is we possibly. What I think you'd have to do is here's the really crux of the matter is sampling error, meaning if you could be 100%, the only way to know exactly what you're dealing with is to have your prostate removed. But the problem with removal is you might have urinary and sexual issues. And for some reason, some guys are just totally scared away by prostate removal. And I understand that. But that's the only really way to 100% know. Now, aside from that, you could ask your doctor to do a saturation biopsy where they do just 20, 30, even 40 cores. And then depending on what they found, you could possibly find another expert to do focal therapy based on the saturation biopsy results. But a lot of people think that that's still iffy as far as its effectiveness, but you could do that, and you could possibly do focal cryotherapy where you just had an area of your prostate frozen, and that would be great if that's where the cancer is located. Or you could have focal high intensity focused ultrasound. Sometimes health insurance will cover those focal therapies, sometimes it won't. So sometimes patients run into problems getting those treatments reimbursed, and it can end up being fairly expensive. But I would say in your case, the only way to know if you could have focal therapy would be to have another biopsy And that would probably have to be a saturation biopsy to give confidence as to whether they were, treating the right place.
Perfect. Thank you. Thank you.
Can I throw in one last question? Because we hear this a lot from our participants. Is there any risk of sexual damage as a result of biopsies?
That's a really good question, and it's not clear because there have been some studies that did suggest that maybe the more biopsies a patient has, there may be, might contribute to erectile dysfunction, but it's so difficult to sort out that with regard to aging itself and stress and other treatments for enlarged prostate and hypertension medications and diabetes. So I don't think there's been a really good quality study done to truly know the answer to that. It is possible that for some men, just getting their cancer treated right at the beginning with a nerve-sparing radical prostatectomy done at a center of excellence still may be better in the long run compared to the guy who was on active surveillance and had 3 or 4 or 5 biopsies, in the first 5 to 7 years. We really don't know, but it's really an important question because really what it boils down to, most of us guys, unless we're it really boils down to why do we do active surveillance? I would ask you guys that, but mostly it's for fear of sexual side effects. If radical prostatectomy, if removal of the prostate didn't have any side effects, why in the heck would you want to do active surveillance? Except for the fear of surgery itself. But I would contend that active surveillance really is around because men are fearful of losing their erectile capability. But maybe I'm wrong. I'm on the phone with a bunch of guys who have active surveillance. Maybe I'm totally off base.
I think you're right. There's also incontinence. I think that can be actually matter to some people. Like I have a very active life. I'm out and about all the time, and I run. So
No, you're right. Even going to look, I do about 120 radical prostatectomies a year, and I think I'm as good as anybody. But the problem is that there's still like a two. Even if I take a guy like you who's 62 years old, perfect health, you have to sign on the dotted line. There's like a 2% risk of incontinence, and like 2% is low, but it's not zero. And so some guys would be risk adverse, even for a 2% risk of incontinence, and I get that.
I'll tell you what, Judd. I know you have to get going. So unless there's final remarks, I'd like to thank you on behalf of everybody in the audience for a very honest, interactive experience. And I hope maybe sometime in better times next year, you might come back and have another session.
Yeah, I'd be delighted. I really enjoy the opportunity. I applaud everyone on the call for being, advocates for your own health and being helping other guys who may be asking you questions. And I hope you'll forgive me for my brutal honesty, and I certainly hope I didn't offend anyone. But I would love to come back at some time. And thanks again to AnCan for inviting me.
Well, I owe you an apology for mispronouncing your name, Dr. Moul.
No, it's all good. It's all good. Believe me, I've heard it all, and I'm not offended. No, I just figured I'd let you know what it really is, but I don't really.
No. I appreciate that, and we do truly appreciate that you joined us.
And next time we'll get it right, and we'll call you Judd.
It's okay.
Anyway, but again, thanks for all the dumbasses and smartasses.
Hey, everyone, have a real blessed holiday season.
Thank you.
You too.
You too. Appreciate it.
Bye-bye.
Okay.